All right. So good morning, everyone. Yeah, so today we're going to be going over a few things. I'm then kind of going to leave it a little bit up to you guys too. Um, so we're going to take a peek at clinical laboratory procedures. And then obviously if there's like animal nursing stuff and all of that, I know some of you guys have been working in some of the other areas. We can definitely, you know, work on that as well. So let's see. Um, so yeah, sorry, we're going to be doing laboratory and animal nursing, and then we should be jumping into imagery, dentistry, and large animals. So we have like a bunch that we can be covering today. But if you guys have anything, because I know some of you guys are going to be taking your test soon, we can kind of jump into anything else as well. All right. So um, good morning as well, Tanya. Thank you. I'm doing good today. So yeah, let's get some questions from you guys or things that you guys want to go over. Just let me know and then we can kind of go from there. Anyone have anything? Fluid therapy and pain pathway. Ooh, that's a good one.
Mine's not really a question necessarily, but
Oh,
I know that I wrote in the, what is it, Messenger on
yes.
Facebook about studying. And you mentioned that people are not like taught to study, and I
Oh yeah.
definitely have not been taught since I had, yeah, anyway. Um,
That's like a
I'm think,
thing all around, right? Like I say that back to even high school, like that should be something that's kind of discussed in high school to prepare you for college, right? So, and my husband's a high school teacher, so I'll tell him that. But
yeah,
um,
I didn't even like finish high school. I dropped out, got my GED, and started working. So
yeah,
honestly, high school was not
yeah, it's
part of
not.
my
So that's
yeah.
even like worse for you because you're so focused on like the actual courses that you're taking that we don't realize that, or not course, like the actual stuff that you need to take to pass your GED, but you're not learning once you go to school, like how to actually retain information from whether it's your teachers lecturing or them giving you videos or giving you readings, like what should you do to make it stick in your brain? And the thing is like, especially in tech school, and then you have, and even like nursing and doctors and all of that, like you have to retain a significant amount of information somehow. So
Right. So I wanted to know specifically, like, if you could look at one of the courses you have set up and
yeah.
say, okay, I would start by doing this. Like, honestly, that would be super helpful
Okay.
for me and maybe other people as well.
Yeah.
Like, if you have the review notes that go over the chapter, and I'm just sitting there reading the entire chapter,
Mhm.
putting more notes in there. And I'm
Yeah.
like, is that not the intention, I guess, of like what I'm supposed to do? Like how would you like break it up, I guess,
Yeah. No,
is yeah,
definitely. Yeah.
yeah.
So, and I've had to learn how to study as well because again, we weren't really taught that in school. But and just FYI, we are gonna have like a webinar I'm organizing with Sam Geeling that going over study tips and testing tips and stuff like that. So she's
Okay.
actually our moderator on
Hmm.
VTNE prep. And then also she's the vet tech of the year this year. So, and she's just super busy, but we're going to get that probably by the end of August, I would say. So,
Okay.
but for the time being, for sure. And you guys can always ask me like other things, even outside of today and stuff. But I think a good way of doing it too is that's why I've set up so many different like avenues for you guys to ask me questions and play off of each other. And that little like chat is kind of nice because maybe you're asking something and somebody else maybe hasn't gotten to it yet or they didn't think to ask it. So they're actually getting that information just like you are at the same time. So I think that's kind of fun. Plus, you guys get to like answer each other and support each other and stuff like that. So,
Mhm.
okay, so some study tips. So when you guys are, especially now, like reading a chapter in a book, a textbook or whatever, like how are you taking that information that you're reading and then applying it to be able to get it in your brain, review it later or whatever? Because ideally, you're not going to be reading that chapter over and over and over again because that's just a lot to read. But how do you do that?
Well, I'm for your course, I've just been following that. Usually you have the review of the
Hmm.
chapter. So I just open up my book and I'm kind of just following along.
Yeah,
And then if I don't like recognize or understand something at all, then I'll just write a little bit about it.
yeah. Yeah,
So,
summarizing a note. Very good. So yeah, that's kind of where I made those review chapter things with questions in there. And what I did to do that was I read the chapter or was reading the chapter. And as I was going through, I was like, okay, important information. Write a question about it here so that when you guys are looking through that chapter, reading that chapter, you're able to just like Ari said that you summarize it in your notes, right? So you're not, one big thing that I think people do a lot of times is like highlight their book.
mm,
And that's great in a sense, but like that's not helping it go in your brain at that moment. So if you can take that information and make some sort of summary in your notes about it, that's fabulous, and try to make it really simple. And then yeah, highlight the whole book. I know, right? That's what I would do before, so there's no white left.
it's like highlight or read the entire thing. And that's why I'm like, I don't have time to read the entire thing,
Yep.
obviously, for
Yeah.
every section
Yeah.
of like large animal
Right.
specifically too.
Yeah. So, and some things as well is, if you're reading that, then yeah, just summarizing what you can read so that when you go back, you have all of that in your notes and those are like your cliff notes, right? Another way to do it too is, let's see if I can do this. I was taught this in high school. Um, and I actually really liked the way that you set it up for your notes. So when you have note taking that you're doing, um, you are, you have your page here, okay? And when you guys are taking notes, are you just taking notes like writing, 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 writing? Most of the time, yes, right? So another way to do it is okay. Another way to do it is that let's see if it'll let me do this. So instead of just writing, 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 you are going to make a line down your page like this, okay, all the way down. And then at the bottom of your page, you are going to make a line, give yourself space. Oops, wait, it's not working. Okay, you're going to make a line like this. All right, and then you're going to write all your notes in here. All right, so anything that you have. On this side, you are going to write questions from those notes of things that you might want to look up or gain or whatever, or even can you make up questions about this? Like further critical thinking based on your notes, right? So just a few questions that you can put in there. And then at the bottom here, you write a summary of this page of notes. So the idea behind it is that you're reading everything essentially twice, right? In that moment. So it does take a little bit of time, but when you get to go back to your notes, you can either read this part of the notes, you can read the summary of your notes, or you have these questions in here to make you say, okay, do I know that question? And if not, you're just looking over here for your notes, right? So there's a multiple ways to utilize your note taking so that you can continue to go back and like exercise your brain with it. That makes sense?
Mhm.
All right. So that was super, super helpful for me in some of my science classes in high school. And then even in some of my harder classes, like parasitology is one of them. I did notes just like this too, because to me, parasitology and I'd say pharmacology were probably my hardest classes. I don't know about you guys. So that way I could go back and read and practice my brain on multiple different ways of doing things. So, um, it's one thing to take just, practicing for the VTNE and taking questions, and answering questions like there's a question A, B, C, D, like doing that. But it doesn't make you comprehend that information because you either get it right or you get it wrong. And it's on you guys to go back with that question and go, oh, I got it wrong. I need to look that up and go back to answer it again. And even in the questions that you get right, looking at that question and trying to utilize that question to the most of its ability and saying, okay, how much do I know about this topic? Number one. And number two, the other answers that are A, B, C, D, right? Maybe the answer was A. B, C, D, what are those things? Do I know what those are? Okay. And why aren't they the answer? So that way you're retaining more and more information just based on small little things that you're doing. And so same thing with like videos. Like I've watched so many YouTube videos and I'm trying to retain the information. I stop that video and take notes real quick, make a summary of it, of what I need to do. Going back to your notes later and highlighting certain things, again, not highlighting the entire page, but highlighting just little things is really helpful. Um, and a big thing too is a lot of people will say, "Oh, I studied, every day for 3 or 4 hours for the VTNE." And it's like your brain will shut off if you do it all straight in a row, right? So you just exhaust yourself. So like if you have to do it where you like, yeah, I can't study during the week. I only have, the weekends to do it. So that's why I take those 3 or 4 hours, just space it out. So maybe say, okay, in the morning, I'm going to do X amount here. Maybe it's an hour here. And then in the afternoon, maybe I'll watch a video and, study an additional hour with some other things, maybe try to break it up. So that's one big thing. I'd say if you're able to dedicate 30 minutes to an hour every day, to study or on average. So like I said, if you can't do it during the week, try to push that, to the weekends and still have that and break yourself up with it. Then you're going to be fine for the VTNE, right? You have that information already from going to school and all of that. It's just a matter of making sure that it's really stuck in your brain and you have a good understanding of it. Like when you read stuff, it should be like, oh yeah, I heard of that before, right? There might be a few things that you're like, "Oh, I was never taught that," but that gives you the opportunity to learn it then. Is that helpful? Um, so I would say too, what is your favorite, I say favorite way of learning? A lot of people say, "Oh, I'm a visual, I'm an auditory," but that's just your favorite way of learning. So let me know what you guys videos, note taking, okay.
In person.
In person. You're a hands-on person, right?
Hands-on.
Yeah, yeah. Games. Oh, games are fun, yeah. So games can be very auditory and again, hands-on too. Videos, notes.
I'm another hands-on person.
Yeah, hands-on. I think honestly, like the majority of us who work, because we're working in a field of a lot of other people and we're learning from people on the job too, that it is super, super hands-on, right? Like how many times are you in a practice and you're just reading books all day? It doesn't happen very often. Maybe if it's a slow day for some reason, which doesn't happen very often. Um, I say videos for sure have made a huge help in certain things, especially recently, right? Like, because we have YouTube, and all of that. Like before, we didn't really have videos. But again, videos are going to be more auditory per se, unless they're showing something in that video, it's going to be visual, right? And then you know, a lot of us, I feel, aren't big readers to comprehend. Especially what I've seen is vet techs aren't big readers to comprehend. Maybe DVMs seem to be a little bit more reader comprehension. That's just what I've experienced. But again, it's not that you cannot learn from those different things. This is just your preference of the way of learning, right? Because that's what makes you feel comfortable. That's what you've done for a really long time. But you still can learn from reading, or if you hate note taking, you still can learn from note taking. I am not a big flashcard proponent. I think that sometimes flashcards can be a really big waste of time to like make all these flashcards. You know, I've seen people like be like, yeah, I made 300 flashcards. And I'm like, are you going to get through all of that? Like, that seems like a lot. Like, sometimes note taking can be just as effective. And then you don't have to make no cards. So, but there are people who are like swear by no cards because again, that's their preference of the way that they learn, right? Yeah, there's a lot. I mean, really, flashcards is just a lot of information. The only time I've used flashcards in class was for parasitology. So I would put like the parasite picture on the front, on the back, I'd put like life cycle, clinical signs, you know, if there's an intermediate host, like all of those little notes on there. And then I laminated them and I made like a bunch of different like copies of them. So we had groups in our class then, and then they quizzed each other on certain things. So they may have like, they'll show like the picture and they'll be like, not just identify that parasite, but oh, you tell me what the intermediate host is for this parasite. And so it just made them have to recall, like not just the picture, but they had to identify that parasite in their brain, right? And then let them know. So again, it's exercising. And even if they get that wrong, they go, nope, that's wrong. It's actually the intermediate host is this. So again, it's trying to stick in their brain. Plus, you have all these other people in the group and they're watching and listening at the same time. Or how many of you guys have ever done like little quizzes and you're like in your brain answering for that person, right? So you're still exercising it. So that's where I think that like flashcards can be good if you again like make it fun and have people really engaged in it because your brain is going, oh my gosh, all this dopamine, this is great, like let me take it all in, right? If you're at home doing flashcards by yourself, like that's not very fun to me at least. So
I guess one of the things too is like you don't necessarily know what you're going to be quizzed on for the test. So that
yeah,
in itself, when you're studying, at least for me too, especially, I'll be reading something. I'm like, oh, well, that might be on there. So I better write it down. And then by the end of it all, I have like 20 pages of additional notes
yeah.
that I wrote down.
And
So
then you're
that's
like,
kind of why,
you
yeah,
feel
that's
like
why I
this
like
big,
the
yeah,
course is like, or the crash course, it's like, okay, well, if I like stick to these categories and just like learn all of this, then I should pass. Like,
yeah,
right? I mean, like as long as I can make
yeah,
my way through all of this stuff and then get it in my brain,
yeah,
it should be a it should be a, you know, a successful
yeah.
test.
Yeah,
So I don't know.
absolutely.
Yeah.
No, I agree with you. So when I was in school back in the day in the Stone Age, right? We did not have, there was no like any uh, you know, vet tech prep. There was nothing. There was not even those review books. So you were truly on your own, or your, you know, your school had to really prepare you. And we graduated, and honestly, luckily, my test was 3 weeks after I graduated, which a lot of people would be like, oh my God, like I'd be freaking out. But at the same time, like I just finished school, it was all in my brain still. And I felt like to myself, I only have to review the things that I feel like not very confident in. And so that was truly like exotics and large animal. Like I learned a lot in school, but it was something that I just didn't feel like as confident as some of the other things that I had learned before. I'd say probably parasitology a little bit too. And maybe farm, but I didn't focus wholly on that. So we had a day that we came in after we graduated to the school, and we literally were there all day. I think it was probably 6 hours we were there. They got us breakfast, we ate lunch, we had a great time because like all of us were back in school and seeing each other and whatever. And then all of our teachers were there and they came in and they had a dedicated time and they literally were like, this is what you need to know. And so it was truly like they were reviewing their own courses from when we started the course or started school all the way till, we just graduated, and they were giving us the cliff notes, right? So we were writing stuff down, we were answering questions, we were really like engaged and again, making it fun. But then they prepared us to be like, okay, now you have your 3 weeks, take that information and go with it. So if you have notes or whatever, and you're looking through your notes and you're like, I don't know what that is, then go back to the book and read that part of the book too. So there's those types of things too. Like you don't have to just go straight to the book and read everything because you're like, oh my God, I don't know anything about large animal. Like go back to your notes and review your notes and be like, okay, yeah, I remember that. That's awesome. I got that. Ugh, I need to review that part again. So whether you take a sticky note and put it there or like write down certain subjects that you need to look up, then go back to it too. So ideally in school, they should be preparing you for exactly what you will be what you'll be tested on, right? That's like the goal when we were teaching was that we need to go over things that could be on the VTNE, which at the same time, I kind of pushed further than that because I was like, no, it's not just about the VTNE. They need to actually know things for, practice wise too. So, but yeah, it is super, super helpful to have the courses now to be like, okay, I don't know this information. I need to look up more of it, whether it is, hey, you want to read the book. If you're like, I cannot read a book, I would die. Like, it's just horrible. Then you might find a YouTube video, like take that, information, put it in YouTube. Like, I bet you there is actually a video out there, right? So try to do those types of things. So things that you're like, yes, I'm going to get that information. I'm going to understand it. Now, when it comes to the practice questions, you guys will notice I don't have a ton of practice questions like some of the other ones. It is only because the practice questions are there to help prepare you for like what those actual questions will look like. And I have them timed in most of them. And so it prepares you for timing yourself to answer those questions. So that's my thing with it. I don't think that throwing a billion questions at someone to make them finish it is truly, truly 100% effective for everyone. It might be effective for this person, but the next person, it might not be effective. So that's why you'll see for me, like I have a lot of different things so that I try to hit everybody. So if you're like, I can't read this or whatever, but I will definitely be able to learn it from a video, watch the video. If you're like, I can't do the video, whatever, I'm an avid reader, I'm going to do that, then do the reading. So there's a lot of different things. But yes, like writing down even just in your notes, like the subject that that you were reading about. Okay. And then when you go back, go, is that really how big is that for me to learn? Do I think that that's something that we would need to know? Or again, ask me, say, hey, do you think like this topic is a big one to like highlight or whatever? Like that's what I'm there for too. So there's sometimes I'll get people who are like, oh my gosh, they focus so much on like gram positive and gram negative stuff. And I'm like, don't worry about it that much. Like, oh, is this bacteria gram positive or gram negative? And I'm like, that doesn't matter. Don't worry about it. Or they'll be like, oh, does this medication treat for gram positive, gram negative? Like those are questions definitely for doctor questions. You don't necessarily need to know that. You need to know what your antibiotics are and the categories they go in, but you don't have to know all of that jazz. Okay. So is that a little bit helpful?
Yes,
Okay.
it is. Actually, when you said gram positive, gram negative, it reminded me of the chart that I went through in the textbook. And
Yeah.
I literally wrote all of the antibiotics and if they were gram positive or gram negative or both.
Yeah. Which, hey, if you know that, good for you. I'm like, oh, let me double check. Like that is my
I-
thing that I'm like, we don't need to know that because we can be in practice and look it up real quick.
Yeah, I don't think I need to know that ever actually, because it is more of a doctor thing. I just,
Exactly.
need to
Exactly.
know the main, the main antibiotics and
Yeah.
generally what you use them for, I guess, is a good,
Right. What
you
you're
know.
going to use them for. Do they have other uses too? Like metronidazole, right? Like it's an antibiotic, but many times we don't use it as much anymore, but many times we would use it for diarrhea, right? Um,
Yeah.
so which works fabulous. But
Yeah.
as we learned with antibiotics, it's going to kill the good bacteria in the gut. So then they have to build up that lovely flora back in their GI system after all of that. So I think those are the things that are really helpful for us to know, right? Because it's not about we need to know that just because we're giving that medication, but we need to know that because who's the one talking to those pet parents about medications going into great detail? Us.
Yeah.
Yeah. So, being able to let them know, certain things like, hey, we actually want to start probiotics first or whatever. And sometimes they'll be like, well, we had metronidazole before and it worked perfectly, but blah, blah, blah. And then you can go in a little bit more detail and tell them. Not only does it help to educate them, but you're building your rapport with that pet parent as well, right? And that's super, super important because it's not just about doctors making having good rapport with clients. It's about us having good rapport with them and our CSRs having good rapport with them. That's what's going to bring them back. Many times I've heard, "Oh, I'll never go back to that hospital because the receptionist was so rude to me or whatever, or the technician was so rude to me." And so the doctor could do everything perfectly, but on our end, we didn't do so well. So yeah, I think like looking at that and being like, okay, is this something that I need to know for client communication? So that goes into that one domain, right? What are some of the side effects? Because again, we need to know some side effects so that we know what we're supposed to look for, and also again, how we communicate that to pet parents as well, right? So try to reframe yourself and be like, is that a doctor thing or is that a me thing, right? Same thing with like, oh, fluid therapy. I know, I totally understand there's some doctors who just give you all the information, all of, whatever. But they do that because they're so used to not having people with that educational background. So they need to do that, right? So now if you come in as a certified tech and have great understanding about it, they can be like, oh, I just want it on maintenance fluids, go ahead and start them on plasma light on maintenance, right? Blah, blah, blah. And you can go ahead and do that. Or whatever. Okay. Can we review? Yes, yes, that's a good one. Okay. So let me get off that soapbox. And then so I have a couple things in here. So here is one question that we can go over. Sure I can. Oh. Nope, this one.
Sorry, for the maintenance fluid rate, it's 2 to 6 mils per kg
Per hour.
for cats and dogs, or what was
No,
the
for dogs. For dogs.
dogs? Okay,
And
sorry.
then cats is 2 to 3 mils.
2 to 3. Okay.
Yeah.
2 to 6 is in my head. 2 to 3. I need
Yep.
to.
Oop. All right. So why doesn't it want me to see if it'll let me do it now? Nope. All right. So we have one of our questions is what volume of 4.5 potassium chloride is needed to prepare. Okay, so our new fluids is going to be 0.75 liters of a 9 milligram per. That doesn't make sense. I think somebody else asked me this, and I was like, this is such a stupid question because it's written wrong. So it says of a 0.75 liter of a 9 mg per mil of KCl solution. Okay. So what they're really meaning here is this, there shouldn't be a mil in here. It should actually be for the full liter, right? Like we want 9 mgs in this solution. Okay.
Oh, you want it to be a 9 milligram solution.
Yep. Of KCl.
Oh.
So this question is written wrong, which sucks. So, and then our answer choices, we'll go over answer choices in a minute, but all right. So the idea here is that we have, this is the concentration of our solution initially. Okay. We're looking for how many mils we need to put in this bag. Okay. So the first thing that we have to do here is we have to make sure that all of our things match. So we're going to either put, you know, this is going to obviously be in mils, or I guess you could do liters as well. So we have to change some of these things. So what's 4.5 percent in milligrams? Because that's just, it's easier to do. 4.5%. So what if you saw this, what would that be as milligrams per mil? Not
45 mg per mil.
good. 45 mg per mil. Okay. So what that means, right? So here's my soapbox again. So it means when we have a solution, it is 4.5 grams per 100 mLs. So anytime you see that percent there with a concentration, like you got a bottle and it says that it's in a percentage, then that's essentially, you can put it in grams per 100 mLs to get your information. So then we're going to move it all into milligrams, right? So 4.5 grams, we know that there's 1,000 milligrams in 1 gram, right? So that would be, we have 1,000 times 4.5, so that's 4,500 milligrams per ml, or sorry, per 100 mLs, okay? So from there, we're going to simplify this, right? So we cancel out the number of zeros that we have. So there's 2 zeros here on the bottom, so we can cancel out those 2 zeros as well, right? And that leaves us with 45 milligrams per ml, okay? So you can do it that way. The other way to do it is if you see this here, or sorry, if you see this here on your percent, people get really confused when they're like, oh, just move the decimal this way or that way. Sometimes they'll get confused and move the decimal this way, or, you know, they're moving it this way. So I always say, if you already understand this, make sure, then that's great. So then you can do this, the cheat method way, right? And take this and multiply it by 10. Okay, so any of those, just multiply by 10. And that will give you your milligrams per mil. Okay.
And then you can also do if you take 4,500 divided by 100 mils, you still get 45.
Yeah. Yep.
If you don't like to do the cross cancellation,
Yep.
right? So,
yeah, absolutely. Okay. Yeah. So yeah, if you're super calculator dependent, go ahead and do that. Obviously, I don't know if you guys can remember back to when I don't even know when we did this. Maybe it was 3rd or 4th grade, right? That was the way that at least I was taught, which was a long time ago. that you can cancel these guys out. Okay. But whatever way works for you, go ahead and do it. So, so we have 45 mgs per mil. That's our concentration, right? And then we know, okay, we're going to have to set this up as a C1 V1, C2 V2. Okay. So we have this side already. Okay. This is going to be in mils because it's prettier. So we're going to have to take this and move it to milliliters. Okay. So how many milliliters is that? So we take, what do we do? 0.75. What are we doing? Multiplying by 1,000? Because it's 1,000 milliliters in a liter.
750.
Good. So we have 750, right? 750 mLs. Oops.
No, I wanted to divide for some reason, but then I said that's not the right number at all.
Yeah. And then we have that we need 9 milligrams per liter.
Mhm. So that's confusing when you say C1 V1 because I know that you don't always have to change things. So I guess that's probably why the question is a little tricky
Yeah.
because you do have to change it to be at
Actually,
least.
let's do it this way.
I
So
thought you didn't change percentages, I guess.
let's do this. So we know that this is now the concentration, right? And then let's go up here. And we know that this is 750 mLs. Okay. This is an easier way to do it.
Almost a whole liter, so it's 0.75.
Yep.
Yeah, that makes sense.
So we have 750 mLs that we're doing, and we need 9 milligrams in that solution. Okay. So what you can do is say, all right, I need to figure out how many milligrams per mil I'm going to do, and then multiply it back. Or actually, we already know. Never mind. Oh, sorry. Duh, this is so stupid. So we figured this out, and we're going to need, because there's 2 things this is what I was questioning with the question. Now I understand. Okay, there's 2 ways. Because they put mils in there, I was like, maybe they meant liters. Okay, so there could be 2 different answers. So if we got this, all right, this right here, this is, now I remember exactly. So we can do it as, okay, we know if they weren't supposed to have it, like at all, and it's just 9 milligrams is supposed to go into the 750 mils, right? We don't have to do any additional math over here. Okay. So what we need to do then is take that 9 milligrams, right? And we're going to say, all right, 9 milligrams is what's needed. The concentration is 45 megs per mil.
So 9 divided by 45.
Mm-hmm.
0.2.
0.2. Okay.
So you're gonna take 0.2 out of that concentration.
Yeah. So,
to put
but
it in
now
there.
if it's per liter, this is why I didn't like the question, because it didn't make any sense. If you do it 9 milligrams per liter, now we have to take that 9 milligrams and figure out how many milligrams we need in that 750 mils. Okay. So 9, divide that by 1,000, because we want to figure out how many that we need for, you know, that. Okay. Then we're going to times that again by 750. We get 6.75 milligrams. Divide that by 45. 0.15. Okay, let me figure this out here. So if they had it as mils, maybe this is correct. 9 times 750 divided by 45. Okay. Nope, I am completely wrong. They are right here. Okay, this is because I'm looking at their answers.
Mhm.
Okay, so if we take that 9 milligrams per mil, that's what they wanted, right? That's what they
Mhm.
wanted. So scratch all of that, me talking bad about that question. So if it's 9 milligrams per mil that they want, we are going to go, okay, well, we have 750 mLs, okay? So 9 times 750 is 6,750, okay? So we're going to take that 6,750 and then divide that by 45. And what do you get?
150.
150 mils, okay?
150 mils out of,
So,
or what?
so yeah, you would need like 150 mLs of your KCl, right? And then obviously your total is 750. So you have to take out 150 mLs of your bag.
Mhm.
So the other way to do it, and this is where that C1V1 comes in, is you can do times, you have this blank, equals, right? We have 9 milligrams per mil on this side times, right? 750 mLs. Okay. So then what
Okay.
you're going to do is, again, this is your X. So you end up with 45X equals what's 9 times 750? That's 600, 750, right?
6,000. Yeah.
Okay. Then you're going to divide both sides by 45. And that's where you get
Oh,
X equals 150 mLs. Okay.
gotcha.
So you can do
So
your C1V1, or a lot of us in practice are like, oh, C1V1 sucks, right? So you'll end up going, okay, well, I know that I have 750 mLs and I need that, 9 milligrams per mil. So it's 9 milligrams per mil. And we have 750 mils. Let's multiply these together. And then once we get that full answer, then we're going to use our concentration and divide by our concentration. But essentially in our brain, that is C1V1 right there. Okay.
if the 9 mgs per mil was in a percent, you would actually keep the percent and still do C1V1, right?
Yep. Yeah.
Like
I
you
mean,
would just, but because it's not, you have
right.
to make them both the same. Is that the,
Mm-hmm.
I guess, the part that
Yes.
I think that's why it confused me, is because I didn't know how to approach it,
Yeah.
because they are different types
right.
of, yeah, okay.
So always your units have to match. So we could have even done 4.5% here and then matched that with making this a percent. The problem with that is, number one, a lot of our brains can't go backwards very easily on that. And we're going to have to find how many mils we need anyway. So you're going to have to end up going into mgs per mil. So that's why I like to do, I like to go into the units that I feel most comfortable with.
Can you do it with a percent really quick, just so I could
Yeah.
see?
How that looks?
Because I feel like these questions, like I remember having a couple on the first time I took the VTNE, like a little confusing.
Yeah. So, and then let's leave the liters too, just for funsies, because then you can see how annoying it is. So 9 milligrams per mil. What is the concentration for that in a percent?
Mm, it would be 90. No.
We're going backwards, right?
Oh, sorry. Ugh. I can't even do it. Can't think.
So if we multiply this time here by 10, then
Oh, divide
yeah, we're gonna divide it.
0.9%.
Good. So 0.9%, okay? And then times 0.75 liters, okay? We'll leave it the way that it was, to the most part, right? Okay, so we end up with 4.5x equals 0.9 times 0.75, we end up with 0.675. Okay. Then we're gonna divide both sides by 4.5. We get 0.15. And remember, we're matching this unit here, liters. Okay. So when you look at the answers, then you're like, oh, well, those answers don't match because they're all in mils or whatever. Now we need to get that 0.7 or 0.15 into liters, right? So then you just multiply by 1,000 and you end up getting that 150 mils.
So if it's 0.15 liters. Oh, okay.
Yeah.
So
So you're changing
right.
your into your units that you need for that question. Because if your answer, if I was just asking you like without an ABCD, like you could leave it like that, you know, because that's a correct answer. It's just that if you're looking at the answer choices and they're all in mils and you are left in liters, you're going to have to change it to milliliters somehow. So that's again why conversions are super, super, super important to be able to know. All of you guys know your conversions, right? Like by heart. And there's like certain things that you can utilize to remember conversions. So if you guys have seen the gallon house that I've made, anyone see that? Or I made the cup one, the cup of teas, I call it. Okay, so those are definitely on Facebook, VTNE prep thing too, if you guys needed to look at it. But that's just a helpful tool to be able to remember it. And again, if you're in your test and you're like, oh my gosh, conversions are going to kill me. Like, how am I going to be able to do this? Just draw them really fast, you know, so that you can remember it. That was a good question. I was being kind of stupid with it. Okay, so on the VTNE, do they provide any formulas? No. No, they do not, but they can provide concentrations and stuff for you. And sometimes they'll give you like you know how you guys for drip rates, I don't give you the drip rate or the drip set. I make you guys memorize that. They many times will give you the like it's a micro set and then they'll put 60 drops per mil. So that's kind of helpful. But no, if it's like no DER, no RER, they're not gonna, they don't really question a lot on the DER because DER can be very variable in some cases. Like one person may be like, oh yeah, I'm gonna do RER times 1.1, and then the next person's like, oh, I'm gonna do it by 1.2. So DER is not huge, but RER for sure. Like make sure you know that.
And the RER is the kilograms times 30 plus 70.
Yes, that's what
Okay.
they use. Yeah. So, you know, and remember, like RER is like that resting energy rate. So meaning that our animals are not doing anything at all, right? That's just to maintain life and their organs and all of that, right? So that's the bare minimum. Okay. DER, or some people call it MER, same thing. They say maintenance energy rate or daily energy rate, right? That is the additional component. Like if they're really active or say they're pregnant, they're going to need additional, you know, support and stuff like that too. So just keep that in mind. Like we have to get the basic RER first, and then we evaluate that pet based on their lifestyle, what's going on metabolically with them, like all of those things, so that we can come up with the correct amount of kilocalories. Okay. Oh, equine limb radiology. Ugh, gross. All right, so let's talk a little bit about KVP and MAS because I get this question all of the time. So get rid of that. So if we're talking about KVP, okay, what is KVP? What is that?
Kilovolts.
Okay. So like,
Penetrating power?
good.
That's how
So
I always remember it.
yeah, so KVP. Okay. So penetrating power, right? And when you said kilovolts, right? But that's like a strength, I guess, of like the kilovolts are the strength to penetrate that patient. So what about MAS? What is that?
Milliamps per second.
Okay. So
Time, maybe.
okay, so we have time. Time is good, right? And then like what does it do?
Contrast? Is
Okay.
it like
Yeah.
the, I guess like fine line or detail maybe
Okay.
would be,
Okay.
or
So
contrast better?
yeah. So MAS is essentially how many X-rays are coming out of the tube in a second, or whatever fraction of a second you have done, right? And how do we determine MAS? So MAS equals, this is the bad part of having digital radiology now, is that you guys don't have to like actually do all of those settings because it automatically does it for you. Because right now on your radiology machine, like what are you setting? Maybe sometimes you're not even setting anything, but you're setting what, KVP and MAS, and that's it.
Yes.
Yeah. Before we used to have to set other things on our machine and then it created MAS. So that's how like it was super, super helpful when I was in school because we didn't have digital radiology yet. So we had to do all of that stuff. So it was already in our brains. Okay. So, oh, let me look at my chat. All right. So MAS, okay, so we know that it's seconds is in here, right? So MAS is MA times time. Okay. So what you are essentially doing is you are figuring out, okay, these are how many X-rays are coming out in the time that we set it in. All right. So if you have a question and they'll ask you essentially like to do the math on it, right? Like if your MAS is such and such and you had MA, how, what's the time or whatever, or what's the MA, right? They'll ask you to figure out one of them, okay? So in here, if you have your MA, let's say it's 300, okay? So they'll give you that. They'll give you whatever it is, right? And then times how many seconds are you going to let those X-rays come out? Now, again, if you did an X-ray and say you put it for 1 second, that is a lot of radiation coming out, a lot. Okay. So it is seriously a fraction of time. As you know, it's like always beep and it just comes right out. It's a super, super fraction of time. Okay. So it's going to be, let's do 1/15 of a second. Okay. So remember, this is our MA. Okay. And that's our seconds. Okay. So if we take 300 times 1/15, what do we get? So it's essentially 300 divided by 15, 20. Very good. So your MAS then here is 20 MAS, right? So that's how you would figure it out, okay? Most of the time we're not going to set it to 20. I was just making things up, right? So, so maybe you have, you know, we're going to do our MA is, again, let's do 200 MA, okay? And then we have for our seconds, we're going to do 1/60th of a second, okay? So what is our MAS? So 200 divided by 60. Technically it's 3.333, right? MAS, okay? So you guys will have certain things like that, all right? So you can set it to that. I think on our machines, like you just go to the next setting, it'll go to like 3.4, right? Whatever, MAS, okay? Now, if they gave you, let's say they gave you, your MAS is 2.5 MAS, all right? And we're supposed to figure out the MA, okay? And they give you the time, and the time is, let's say 1/30th of a second, all right? We'll see if this works out nicely. So how do we figure out MAS? Remember, there's a,
MA or MAS?
oh, sorry. How do we figure out MA? Sorry, I'm good.
Okay, MA.
All right. So essentially we're going to, this is X, okay? So we end up with
75?
okay, let me make sure. Yep, 75, good. So yeah, so just you're dividing out that 1/30th of a second, you put it on this side. And then if you ever have division, right, with a fraction, how do we do that? You flip the fraction over, right? And then multiply it. So very good. So what if they
So
give you MAS and then you need to figure out MA? Is that a thing? Yes. Oh yeah, right. They can even do it so that you have to figure out the seconds too, right? But you're just doing the exact same thing. Like
I missed that. I'm
way.
sorry. I got the answer for that, or I heard the answer, but what did you do again? So you did 2.5
Yeah, so
equals
2.5 equals that X times 1/30th of a second.
uh-huh.
So you're gonna then, right, we have to isolate this X. So you're gonna
Mhm.
divide both sides by 1/30th, right? So
Oh,
it
gotcha.
essentially is gonna get you, you're doing 2.5. Sorry, I don't have my pen today. So I'm just doing it like a weirdo. 2.5 divided by 1/30th. And we can't divide that, right?
Mhm.
Or it's just ugly, right? So instead, what we're gonna do is we are going to, I'm just gonna come over here. We're gonna take our 2.5. And when you have something that says you're dividing a fraction, you
Mhm.
flip it upside down. So we're gonna multiply it. Multiply. And then you're flipping it upside down, so it's 30 over 1.
Yeah, and then you put 2.5 over 1.
Yep.
So I mean,
Yeah.
yeah.
Yeah. So then you're just taking, because that ends up equaling 30, right? So you take 2.5 times 30,
Right.
and then you get 75.
Okay. Sorry. I missed that.
That's the other hard part, I think, with math for everyone is a lot of our math stems from very basic math we learned in like 3rd or 4th grade. And that was so long ago for a lot of us. So certain things like, you know, hey, we got to flip this around because we're dividing a fraction, or how do we divide a decimal? Like, sure, we can do it on a calculator, but at the same time, we still have to know and make sure we know that that's correct, because our calculators can screw us up sometimes, right? Because the calculator doesn't do, as you guys know, oops. You guys have heard of this, correct? What does that mean?
Was that the order of operations?
Good, order of operations, right? Have any of you guys ever tried to do order of operations with your calculator? Or do a question on your calculator and it's not actually correct because it doesn't understand the order of operations here. So you may
Mhm.
have something like 1 minus, you guys will see this on social media all the time, right? They'll be like 3 minus 4, you know, and then have like 5 plus 6.
I actually love those questions.
Minus 2. Or should I do that? Oh, let's just do this. Times 2. That's how I want to do it. And it's fine. Okay. So what do we get? So you have to do order of operations. So what do we have? What's the P?
Parentheses.
Parentheses, right? So we are going to do our parentheses first. So that's what? 11. And then what?
Multiply.
Okay.
11 times 20 times 2 is 22.
Okay. Times 2 is 22. So now we're at 22. And then what? So we end up having 3 minus 4, and then it's plus 22 because this is a positive, right? Equals what?
23. Right?
So what
Oh,
comes
sorry.
first?
Addition.
Okay. So we end up getting, what is this, 26?
Mm-hmm.
So let's do 3 minus.
3 minus 26. So negative 23.
Mhm. Very good. But again, if you do it in your calculator, it won't come up like that. So that's where we do need to remember some of those small things, because that will change our answer. So you have to, if you're going to use your calculator, you have to take it step by step. Okay. All right. So let's go back to this. Like, I think what you guys were originally asking was, how do I utilize, and know truly what KVP is, right? So we figured out like how to do that, you know, calculations and stuff like that. And truly what MAS is, right? It's MA times the seconds, right? So this is the power, I guess this is the number of x-rays coming out of the tube in the seconds that it's set for. And that's our MAS, right? So it's giving you the contrast of the entire x-ray, okay? Now, KVP is penetrating power, and I think penetrating power to our patient, okay? So the P is really important here, like it's penetrating the patient. So we're setting that to be what it is. Let me just change this. So X-rays per second. Okay. So penetrating that patient, that contrasts at least that patient, essentially, not the full X-ray. Okay. So if we're looking at an X-ray here, let me try to draw an X-ray. Okay. And then we have our patient here. Right? Such a great visual. If the patient is too dark and the rest of the X-ray looks fine, what's the problem? Is it KVP or MAS?
KVP.
KVP. Very good. All right, so that means we got to change that KVP, right? So how do we change that KVP? So let's say that our oops. Okay, there we go. Let's say that our KVP is set to 60. Okay. So it's set to 60 and it's too dark. How do we change it? Are we decreasing it or increasing it? Turn it down. Good. So we're turning it down. We're going down with our KVP. And because how I think of it is toast, right? If we burn our toast, we need to set that toaster, we need to set it down, right? So it's the same thing with our patient. So if something's dark on our X-ray, we need to figure out what it is, what's the problem. And then if it's dark, we turn it down because we have burnt our toast, right? If it's too light, we turn it up because it's too light. We need to like toast it a little bit more, right? So
There's
when
a formula for that, right?
yeah, there is a formula for that. So for KVP, we are going to change it by what? 10 to 15%. Very good. So we change it by 10 to 15%. Okay. So if it's too light or too dark, we're going to determine if we need to go up 10% or down 10%. Or if it's like really, really dark, we go down 15%, you know, that kind of thing. Okay. So it's adjustable. What about MAS?
Is that one 5? Or did I just?
No, not 5. Let's see. 20 to 30. Close.
Hmm.
So it's 30 to 50%.
Hmm.
Okay.
Yeah. So close.
So I usually, like, if I'm in practice and just adjusting it, I usually, unless it's super, super burnt out, I usually use the very bottom because I want to tweak it. Now, that was the problem when we didn't have digital, was that what you get is what you get. Like digital actually like fixes a lot of it for you. So if you didn't toast it enough, it might fix it, like jump and fix it really quick. And that's really nice because that's less x-rays we're taking. I can remember retaking radiographs. I don't know if some of you guys have been in the field long enough for non-digital radiographs, like the manual. We would sometimes, it'd be like 5 or 6 times because of certain patients or whatever, like just for one view, right? So we were exposing ourselves and that patient especially to several radiographs that were not even used.
And then you would have to wait for it to develop to see
Oh yeah, it was
which adds
terrible,
on
right?
time and everything.
Yeah, so if you did the automatic processor, which is amazing because it cut down the time a lot from manual developing. If you ever manual develop them, it takes like 20 minutes to develop it. One x-ray, one. And then automatic processing, I mean, we got real good at like changing out and doing all of that, right? So it would take a couple minutes, you know? But like it was nice because digital's nice because it alleviates the risk of you exposing that radiograph that you weren't supposed to after you took it. Like maybe you had the light on or the door opened or whatever, right? You could expose it. So you had to be in a dark room to be able to develop it. There would be other things. Sometimes the automatic processor would get jammed and it would ruin your x-ray. It didn't happen all the time, but once in a while. So it was just annoying, right? So it just kind of alleviates some of that. So going back to this, if we're turning it down 10%, right? We're going to turn it down. So what is 10% of 60?
6.
6, right? So we're going to turn it down. So that means we're taking away 6 and it's going to leave us with 54. Okay. So you're going to set your thing to 54 because it was super burned. The patient was too dark on there. And then you are going to retake it and hopefully it'll be beautiful. If it's still not, still too dark, then you go ahead and turn it down a little bit more. Okay. So this
So
is
is it up or down?
10.
The percentages stay the same.
Yep.
It's either, yeah, okay. So either way you're going up or down, the percentages always stay the same between
Yeah.
those.
Yeah. So these are like guidelines to try to help if it's really bad. But sometimes when we would take it, we would be like, oh, let's turn it down 10%. And it was still too dark. So we'd have to go down another 10%. So it's like a guideline to get you to fix the problem that you have, but it's not always perfect, right? So now let's say that our background here is super, super light. Like your background should be black, right? And it's hard because a lot of you have digital. If you've ever had a radiograph that the background is like just like gray, like a light gray. So if it's a light gray, it's going to still turn your patient lighter too. But if the background is gray, we know it's truly the background that's the problem. If it was that the background looked fine and your patient was just really, really light, that's when you change the KVP because your patient is too light. Okay. But if the background is very gray, then we're like, oh, not enough x-rays came out to actually expose everything. So let's say that our MAS is 2.5. Okay. And it's too light. So what are we going to do?
Increase the,
Yeah, we're turning it up. So let's turn it up, okay, by 30%, right? So times 30%. What do you get?
$75.
0.75?
Yep.
Okay. Because again, when you're doing a percentage, right, it's 2.5. You have to turn this into a decimal times 0.3. And then that gives you 0.75. So 30% of 2.5 is 0.25. Okay. So we take 2.5 and we are going to do what? It's too light. So we're increasing to 0.75. And that ends up giving us 3.25, right? So we're increasing that. Okay. So you guys understand at least now, like the difference with KVP and MAS? I find it to be super, super helpful to look at it like it's toast. Perfect. And you'll have it too, like in practice, you might have it where you have to change both for some reason, right? Like maybe you exposed it and like is all just dark. That seems to be kind of one of the big ones. It's all dark. So you'll change maybe the MAS and then you fix the MAS and then you look at it and you're like, oh, now the patient's still too dark. And then you have to change the KVP, right? That happens once in a while, but it's not huge. Great. So this is also the same for dental radiographs too. The numbers are just a lot smaller. Okay. So there's a KVP for dental radiographs and an MAS. And if it comes out too dark, then you're going to have to change it, go up or down and all of that. Same situation. Okay. It's just easy now in dental radiographs because it's all set for you. Again, because it's digital for the most part. I don't know if anyone else has non-digital at this point. So how about developing radiographs? Yes, we have digital now. However, you guys do need to know the difference when it comes to developing them.
You
So-
need to know the order as well,
Yeah.
right? Because that'll probably be asked.
Yeah. Anyone ever develop radiographs or dental radiographs too?
I had to.
You do?
I used to. It
Oh, okay.
changed like 2 years ago.
Where do you live?
Alabama.
Oh yeah. Okay.
A little slow back here.
Yeah, it's okay. So the thing is, I used to work for AHA. So I used to go to a lot of hospitals like all over the country. And you know, I would go to like a really, really small town in like Missouri, and they still were developing radiographs and stuff. And it's like they understand that they can get digital radiographs, but if it's a really small clinic, they have to prioritize their money because like to get digital radiographs is very, very, very expensive. And depending on where you're at, maybe you're not doing that many x-rays or whatever. So it's like, I'd
Yeah,
rather
the only reason why we changed was because it broke down finally.
and you can't get another one, right?
Yeah,
Oh my
pretty
God.
much.
So when you're developing radiographs, you are going to have essentially 4 containers. Okay. And so even if you're doing the automatic processor, it's doing the exact same thing, having 4 different elements to it. Okay. Even if you did manual, if anyone ever did manual, it's the same thing. You're doing 4 different elements to developing an x-ray. Okay. So what are our 2 chemicals that we use? Okay. So we have developer and fixer, and then we have wash stations, right? So remember this, that with the developer, it's developing your x-ray. And so if you fix it right away, fixing or the fixer means that it's like locking everything in so it doesn't go away. Okay. I think of it as like if you're painting your nails, it's the clear coat so that your, nails don't chip, right? So the fixer, if you did the fixer first, which we used to do all the time when we were clueless little technicians out there or assistants out there, right? Like we were still learning, you don't make that mistake again. So you fix that radiograph and then you take it out and there's nothing on it, or you put it in the developer. Well, the developer can't develop anything because you've already fixed it. So we screw up and we have to retake that x-ray. It sucks. So the first thing is to develop the x-ray or radiograph, okay? After you develop it, you're going to rinse it or wash it in just water. There's just a water. We used like sterile water, but other people use tap water. It's up to what you want to do. Now, you could technically take out that radiograph and look at that radiograph at that moment because it's already developed, okay? The problem is that the developer will not stay on that radiograph for very long. So we did this actually when I was teaching. We still had chairside developing for dental radiographs. So I was like, hey, I want you guys, we have this extra one. We would take radiographs of like skulls and stuff for practice. And so I was like, take this radiograph. I want you just to develop it and let's see how long it lasts on that radiograph. So it's like a good visual for people to like be like, oh, that's why we have to fix it. So it literally stayed on for like maybe half a day. And then you could see it like fading away and stuff. So you develop it, you rinse it, you're going to put it then in the fixer. Okay. that locks it all in. All right. And so you leave it in the fixer because you really want it to be locked in there. So you're leaving that in there. If it's like a chair side developer, like a minute. If it is in, you're actually doing manual developing, it's going to be much longer. It's going to be like 15 minutes. It's long. It's very long. And then after you do the fixer, you're going to definitely be rinsing it with your water. Okay. Make sure you rinse it really, really well, because fixer, if you get it on you, it stains your clothes. It's like almost like a bleach stain. So you really, really want to rinse that off. Okay. So does that make sense? So you're developing the x-ray and then you're locking it in with the fixer. Okay. There were some people, oh my gosh, when I first started teaching at one place, there was a teacher prior to me that actually had like this all weird. I don't even know how they did it. But the first one they did was rinsing the film and then developing it. And I was like, you don't need to rinse it. I know some people think like if you rinse it first, then it's gonna like make the radiograph a little bit more pliable. But the problem is that if you don't get it into the developer quickly, you may expose it and not be able to get the image that you want. So you just want to take it out and throw it in the developer right away. Okay. If you had automatic processing, it was kind of like, for you guys, if you haven't seen it, it's kind of like a printer backwards. Like you're pushing it through rather than it coming out, right? So you push it through and it goes in and then it beeps at you, you know, that you got it in there and it's going or whatever. And then it goes through its process and then it comes out like a printer, right? So it's just automatically going through. So. Okay, what the exhaust, replenish, and they ask about refill. I'm trying to figure out what you are asking there, Wendy. Not quite sure. So if you had an automatic developer, I think, are you talking about for imaging or are you talking about surgery or something?
Was the how often do you have to change maybe that's what she's asking?
Oh, to refill the developer containers. Okay, that's a good question. Honestly, I have seen people keep, like if you're doing share side developer or whatever, that they keep that there for like a week or whatever. It's just that it's not as good for that period of time. Number one, the big part is looking at your actual like developer and fixer to see what it says. That's a big part. I always used it for the entire day. For chairside developer for dentistry, used it for the day and then discarded it. So just because we didn't use a lot of it, so, and we were school too, so it's not like we were going through it. But if you're in practice too, you're using it pretty well, like pretty long. So you just don't want to have any contaminants in it. So that's the big part. So how are we supposed to discard fixer and developer technically? Kitty litter? No. And people say this too, like even for like controlled drugs or whatever, they put it in kitty litter, right? That is the only reason why they did that before was that so people couldn't use it later. So they were having it be absorbed in something and then getting rid of it. The problem is that certain things are either hazardous or like you can get in trouble for the DEA, right? Good. So they have those biohazard drugs that you can use. And then because it goes into that drug and is absorbed by whatever is in there, like carbon or whatever, then you can throw that away. Or some of them you have to like actually have whoever collects like your sharps and stuff, they can take those things. So it just depends on what you're using. But the kitty litter is like a no, don't do that anymore. That's old school. So those biohazard drugs are super, super great. They're huge. They're like a gallon jug. You can just dispose any items in there like any unused medication. So say you did propofol, right? And you gave so much propofol to a patient. We shouldn't be putting that down the drain because it's going into our water system. So it should go into that jug. So you discard it, right? So things to that nature. If you have a whole bottle of a controlled drug and it like say expired, what do you do with that?
Well, you have to write it in your book if it's controlled. I mean, it
Yep.
needs to be
Yeah,
logged
absolutely,
first.
absolutely. But how do we discard it?
There's specific, like we have like a bottle or a jug,
Okay, so there's that.
or there's, yeah.
But if it's a full container, like
Oh,
a full bottle,
Don't you send it back to the manufacturer?
you send it, I'm sorry, to where?
You send it back to like where you purchased it from.
You might be able to, but typically you're sending it to what's called a reverse distributor. So you're sending it to a place that actually discards it for you. So they incinerate it. Okay. The problem with that is it can be really expensive to send all that stuff out. So that's why you'll like your practice managers or your doctors or whoever, like that's why they limit that's one reason why they limit how much controlled drugs that they have at a time because they don't want it to expire. The other reason why they limit it is because they can only get so much at certain times because of their license, right? We can't like have them order all of it. Looks weird when you're ordering all of that. And the more that you have in practice, it is a big deal, right? Like that you could have that stolen, not just from staff members, but I have seen it too, where, you know, someone breaks in and gets into the lockbox and then they take a ton of controlled drugs, right?
do you also have anything? I know someone mentioned the equine imaging. Do you
Yeah.
have anything for the basic equine imaging?
I
Jenna?
will send you guys stuff on that so you can take a look at it. Because I think that'll be easier. Oh, you found a YouTube video. Very cool. Yeah, if you can share that if you find it, on like our Facebook page, that'd be awesome, honestly. And then I can incorporate that into certain things too. That's awesome. Equine's hard because it's just like, number one, you have to know the anatomy of that leg pretty well. And then yeah, the views are going to be a little bit different, especially because that patient's not laying down, that kind of thing too. So you have to maneuver yourselves. Okay. So the reverse distributor, they incinerate everything for you. And then yes, you do have to fill all the paperwork out and stuff like that. I mean, it's a lot of money to have like a controlled drug to begin with. And then, you know, because you're buying it or whatever. And then if you dispose of it, then that becomes an additional expense. So that's hard. All right. So, oh yeah, our equine view is similar to bisecting angles used in no, kind of, but not really. Like, it's more like, I only say kind of, but not really, because sometimes you're doing some like obliques, but the obliques are going to be different. So, I mean, it is a lot like small animal. It's just that you are positioned differently for that animal because the animal's not laying down. And that way, when it's positioned, you have to remember you like cranial, caudal, like all of that stuff. So I think that's the big thing about it. So yeah, I mean, definitely take a look at it. Okay, so we had another question here on my favorite question I like to give you guys on the ace promazine. And it's funny because people are always like, oh yeah, that question, right? Okay, so if we have what volume of 10 milligrams per mil of ace promazine? So, oops, promazine. Solution must be mixed with diluent to yield a final concentration of 2 mg per mil. Oh, this is a different one. Okay. Oh, yes, I remember this. Okay. All right. So if you have ace promazine, the concentration is 10 mg per mil. Okay. But you need to dilute it to get a final concentration. So our final concentration, I thought you were asking the one that I do, is 2 mg per mil. All right. So this is our current concentration. All right. So if we set this up here, all right, if we're like, okay, we have 10, we're going to do 10 milligrams. This is C1V1, right? 10 milligrams. And this gives us 1 ml. All right. 10 milligrams. There's 10 milligrams in 1 ml, right? But we need 2 milligrams per ml. Okay. So let's say, for instance, we have to figure out how many mils of this 10 milligrams we're going to use. All right. So let's just say for fun that we have 2 milligrams and it's saying per mil. Okay. So times 1 ml. Okay. We have to figure out how much of this 10 milligrams we're going to put again in 1 ml of total concentration. All right. So if you do all of this, it's, remember, 10x equals 2 times 1 is 2. Okay. So we divide both sides by 10. X equals 2, or sorry, 0.2 mLs, right? So if we just did that on our own and we look at the answer selections here, we're going, oh, none of those fit, right? So then we have to say, okay, well, this is 2 mLs of, or 0.2, I keep saying it, 0.2 mLs of our ace promazine. And then we have a total concentration of 1. So we take 1 minus 0.2 is 0.8 mLs of diluent. All right. So again, when we look over here, we're like, nope, none of these fit, 0.1, all of that. But what do you see maybe that we could work with? Can we simplify this down, right? So how do we simplify? 0.2 divided by 0.8, right? Can we simplify that more? Yes, because 0.2 goes into 0.8, right? 4 times. Okay, so that means that we can go, okay, 0.1 mLs is ace promazine, and then 0.4 mLs is the diluent. Okay, so ace dilute.
So you're saying this is a C1V1 question,
Mm-hmm.
but when you say 10, when you put on the left side 10 mgs per, well, so you don't have a, I'm
So you
confused
can
because you
do
put a 1 for the volume
at
for
first.
the
So you
other
could
side.
also do it this way too. Right? You could do it this way.
Because
And
it doesn't look like we have a volume.
so you have to put in what your volume is going to be. So think about like if you are in practice and you're like, okay, I need to make a diluted solution to get that 2 mg per mil. Okay. You can put whatever you want as your total, whatever you want. Oh, I want to dilute it to, maybe I'll do 5 mLs, right? Like you can do that. It's just once you simplify it all, it's still going to simplify for your answer to 0.1 mils and to the 0.4 mLs. Okay. I just did 1 because that's the easiest thing to do, at least at first, right? You can always multiply it later if you need a bigger solution or whatever. But, sometimes if we're looking at it and we're like, this happens all the time with acepromazine because some animals are so small and we need to give like really small doses. So we have to dilute our acepromazine from the 10 mg per mil to 2 mg per mil. People do a lot. Or they even do 1 mg per mil. I don't know if any of you guys do that in practice now.
It still seems
Anyone?
confusing for some reason. I'm not sure.
It's okay. So let's look at it this way. How does anybody use the 1 mg per mil in practice? Yes, no. So if you are in practice and you need to make a solution that is 1 mg per mil, okay, you have a 10 mg per mil solution, okay. A lot of times what we'll do is we'll put it in its own little vial, right? And so if we put it in its own little vial, okay, we get to determine how much volume we want to have in there, right? So maybe you're like, oh, we're going to use this for multiple patients today or whatever. Or maybe the vial holds 10 mLs. Okay, so you're like, okay, let's just make a whole bottle of it and do 10 mLs. So let's not do the 1 mg per mil, but let's do the 2 mg per mil so you can see what that looks like. So if I'm going to do a whole bottle of it, so I need 2 mgs per mil. All right. And then I'm going to do a whole bottle of it. So I'm going to have a total of 10 mils in that bottle, right? So now we're going to go, okay, so 10x equals 2 times 10, right? So that's 20.
And
Okay.
you're mixing it with what? Saline or what
Yep,
are you?
saline. So your dilutant's going to be saline. Same thing with this, okay? So then we're going to divide this both sides by 10, right? So you end up getting X equals 2 mLs. So that means that you're taking 2 mLs of your acepromazine.
But you need 8 mils of the
Yeah. So 8 mLs
diluent
of your
of saline.
diluent. Yep. Of the saline. I'll put that.
I guess the first time that you did it though, you didn't have an end mils,
Yeah.
right? Or how did that?
So my end
Something.
mils here was 1 ml. So I was just making a small amount.
Oh, okay. And the question provided you with that, I guess.
The question doesn't. It doesn't tell you.
Oh, it doesn't
Now,
tell you.
it will tell you here in the answers. So if it didn't have any answer selection for me, I could make up whatever I want. But here you could go, oh, okay, if I add these together, I have 0.5. Does that work? If I add these together, it's 0.5 again, but does that make sense? No, so that one's out. If I add these together, 1 mil and 0.4 mLs as my total, does that work out? No. So you could do that too. I choose to like just try to answer that myself and then make that. So I'm like, okay, well, can I simplify the 2 mils for 8 mLs, right? Yes, I definitely can. I could do 1 ml of acepromazine, right? Because 2 goes into 8. And then that would give me with 4 mLs of saline, and the total would be 5 mLs, right? So that makes sense, but that's not in our selection choices.
Gotcha. And this is just a question that came out of like the
Yeah,
work.
I think, yeah, it was someone posted it, I know, earlier in the week. So I'm glad that we're going over it too.
Usually if you're, well, I guess if you're talking about like the test, they would generally provide you with like a total end, right?
No,
Or is
they
this
don't
just
have to.
something that,
Yeah, you're gonna
okay.
have to look at this. So like this is like a test-ish question. You'll have to look at it and go and remember that like when you're making solutions, that it is this total, right? Just like if I were to say earlier when we were like, oh, it's 750 mils total, but 150 mils is going to be KCl, we have to take out, you know, that 150 from the total. So you end up having 600 mLs of fluids and 150 mLs of KCl, right? So they're just ensuring that you know, number one, how to make a total solution the way that it should be. And then also, can you simplify this down to what they're looking for? So they're essentially evaluating a couple things with just that one question. All right. I'm just looking through this. Okay, are there any veterinary hospitals still using the previous version of x-rays, not digital? So automatic x-rays. Yes, automatic processing. Yes, there are. There are actually more than you think. There are also hospitals that are still doing manual developing. So dipping, like that. When I was at AHA and I got to see all these different places, there are people are like, oh, well, if it's going to be manual, it's probably going to be, you know, somewhere super, super remote, blah, blah, blah. Sure, that makes sense. I actually went to a hospital like in Chicago. They were in Chicago and they were still doing manual processing, sorry. Yeah, developing. But they were hopefully shortly going to digital, which is a huge jump. They completely skipped automatic processing. So, all right. Okay, here's the other one. Let me get rid of that.
Sorry, quick question before you get rid of that.
Oh, sorry. Here.
It's okay. I was trying to think about, and I'm sorry if this is annoying and everyone else gets it, but when you said X equals 2 mils of acepromazine and then the 8 mils of saline, and then you said you wanted to break it down even more, why are you doing that again?
Oh, just because you can.
Oh.
So like maybe you're like, oh, I don't want to use that much acepromazine, right? Like,
Oh, okay.
to just whether or not you're going to waste it or whatever, right?
Oh, okay.
But yeah, you could break it down and just do that. Just like
a real life scenario, I guess is what you're saying.
Yeah.
Like I want to use like 0.5. Okay, I'm going to use 0.5 mils instead. Because like who needs like 2 mils of acepromazine?
Exactly.
Not many. Okay,
yeah.
Got it.
So like if you are only using it for one patient, you may do like 0.5 or 1 ml. Or there are people that are like, oh, I'll save it, blah, blah, blah. And they save it in the lockbox for some reason. I don't know why. And they'll make like a whole bottle of it. So like you can do whatever you want on that. Yeah.
Sure. Got it.
Okay. So a 10-year-old male neutered pug presents in respiratory distress. Shocking. And appears to have an allergic reaction. Aw, that happened to my parents had pugs. And we had a pug when I was younger that had an allergic reaction to her Lyme vaccine. Shocking. And her face was so swollen. It was really cute, but also scary. The doctor wants you to get oh my God, epinephrine ready at a dose of 0.02 mgs per kg. And the pug weighs 9 kilograms. That's a big pug. When you get the bottle of epinephrine from the refrigerator, it says it is 1 per, I guess this 1 1/1000th of a solution. Okay, so this is our epi. How many mils will you draw up? Okay, so let's start with just at least the easy part. So 0.02 mgs times 9 kilograms. Okay, so how much do we need? All right, so 0.18 milligrams. Okay, so how do we know what 1/1000th is?
Is it 1/1000? Because it's the same, right? So you could take it both ways. 1/1000,
Okay,
and then
good.
you divide
One.
1 divided by 1,000.
Good. So it's 1/1000. But what is our
Oh, gram
good?
out of 1,000 mils.
Good. Okay. So that should help you guys to be able to figure that part out, right? So if we want milligrams per mil, it is 1 gram times 1,000, right? 1,000 milligrams is 1,000 milligrams divided by 1,000 mLs. Okay, so now that means that this equals 1 milligram per ml. And you're all probably like, why didn't I just write that? All right, so if it gives you something like this, it means that it's 1 gram per 1,000. So if it said that this is 1 per 500, you know, 1, I don't know, 1 per 500, right? What does that mean? It means that it's 1 gram over 500 mLs. Okay, and then you figure that out from there. All right, does that make sense? That you guys cool on that? People get so worried about this, but as long as you know what it means, that this is a gram per whatever mLs is in here, then you can figure out the rest, right? Okay, so we're 1 milligram per mil. We need 0.18. So we end up getting what? 0.18 milligrams divided by 1 milligram per ml is 0.18 mLs, right?
Mhm.
So it seems like a super, super scary thing. But it's pretty easy. I think sometimes with atropine or something, you may see that where it's like, I forget now. I think it's 54 per 100 or something like that. You may see that. Or 5, I don't know. It's something like with a 54 in there. So there are certain drugs that you'll see that. Epi is a good one, right? To kind of practice on. So, some of the other drugs that are a little bit different, like mannitol is different. Sometimes you'll even see like calcium gluconate look a little bit different. So just kind of keep an eye on that. All right, what else do you guys have? Let me think.
I have a random question. There was something, why is etomidate recommended for induction? And I think I wrote this note saying positive cardiovascular
Yes.
effects question mark.
Yep. Yeah,
So
so
that's the answer.
yes. And so it would be good for what type of patients? If it has positive cardio, I'm just gonna say positive cardiovascular, right? So
Patients with cardiac disease.
yeah, any patient with cardiac disease, right? And that is not just There's sometimes we have some acute cardiac issues, and this is when I've used etomidate, is yes, heart safe. I love that. So yeah, anything with arrhythmias, congestive heart failure, but if you're working emergency, there's something that comes in that is actually technically a cardio patient, but there's something else that's going on making it that they're a cardiac patient. What is that? And you guys see it probably a ton, especially in the fall. What's pH? Almost. Oh, pulmonary hypertension. Okay. No, I mean, yes, but no, like that's not what I'm thinking here, that we would use etomidate because pulmonary
fall?
hypertension. I'm sorry.
You said in the fall?
Yeah, it happens a lot in the fall. I feel like it happens a lot in the fall. I'll say this, it happens in cats, mostly. Male cats, especially.
Getting blocked.
Yeah, they're blocked, right?
In the fall? I was like,
Yeah.
wait, what?
Yeah, to me it happens a lot in the fall,
Oh, okay. Okay.
like more frequent for some reason. But obviously we still see block cats throughout the year, but it's just
It's
like,
one of those superstition things where
Mhm.
you're like, it happened and now it's forever
Yep.
that way.
yep, just like GDVs all come in like late at night, right?
Yeah.
Yeah. So the reason why I say that they're a heart patient is because yes, they cannot pee. That's a big deal, right? Like that's painful. It's horrible, but that's not the emergency, right? The emergency is the fact that they cannot get rid of that potassium. Very good, Danielle. They can't get rid of it. So, what we have to do is either we have to essentially get rid of it. We have to unblock them and help them. Now, the problem is that a lot of times their potassium goes really, really high, and that's going to like affect the heart, right? It can cause arrhythmias. It can kill the patient. So we have to treat this patient, even though they probably don't have previous heart issues. We still have to treat this patient as like a heart patient when we're giving medications until we can get that potassium down. So I've used etomidate in those cases. A lot of people don't use it that often though, because it is really expensive. But it is really good for our patients. I tend to see a lot that people are using, oh my God.
Ofaxalone.
Thank you. I'm like, oh my gosh, why is it not? Yeah, Ofaxalone a lot more. And the reason for that is because yes, Ofaxalone is expensive, but etomidate, once you open the bottle, you have to discard the rest of it, where etomidate, you don't have to discard it as quickly. So that's why they use that pretty much. And you are essentially treating them both the same. So alfaxalone, many times we couple it with like diazepam or midazolam or something like that. The nice part about doing diazepam and midazolam for a cat that's being blocked is it's relaxing that patient. So it's going to relax that urethra, right? Because right now it's just like really upset and your doctor's going to have a hard time like passing a urinary catheter. But if we can give some diazepam or midazolam, so a benzo, to that patient, it's going to help at least relax everything a little bit more. Okay, so keep that in mind too. There are other people that obviously like give alfaxalone, but they might do something different. Maybe they're getting ketamine on top of it, or whatever. You know, they all want to do something different. But what happens if we just gave straight up alfaxalone to a patient? I don't think anyone really does that. We usually do a pre-med at least, or, you know, you give some medication with it or whatever. You have trouble with that patient when they wake up? Anyone ever see that? Where they're just like wake up really, really awful. It's not like they have a huge excitement phase. Let's say that, right? Yeah, it's crazy. It's crazy. I was at a place for a little bit that the doctor there clearly did not understand some of that stuff, and ended up like every single patient would wake up insane, and I'm like, hey, can we actually couple it with something else? Blah, blah, blah. It was something else. But there was one doctor that I was trying to get the patient off of the table. It was a spay. And the patient woke up again, crazy, and was just like starting to try to bite everything in its way. Like, again, it was a puppy, like it wasn't gonna do any normally. It was super, super nice, right? So it was all drug related. And I was just trying to calm it down and whatever. And just side note is that the doctor that was there ended up picking up the dog by its scruff and throwing it in a cage. And that was the day I just walked out. I was like, I'm done. I'm not doing it. Nope, nope, nope. We don't do that kind of stuff. So yeah, just keep that in mind. Like certain drugs, we have to couple it, and that's why, you know, we have to complement each of those drugs so that we can help that patient. Yeah, definitely. So alfaxalone, that is a really good thing that to know is that have something with it, whether you're pre-medding that patient with it or whatever, at least an opioid with it, something. But I personally like utilizing, whether it's, you can use a little bit of ketamine in there, I love benzodiazepine with it too. So it's just helpful. It makes them a little bit smoother waking up and that type of thing. So we have one more. So murmurs associated with the cardiac valve will be best ausculted over the right fourth intercostal space in a patient. Okay. So this is where we need to know where our valves are located. Okay. So I'm going to draw my little patient here. Don't make fun of me. Okay. Draw my patient. Big fatty. Like my legs. Cute. And then a tail. Okay. So, sorry, my daughter is looking at me like, what are you talking about? Okay. So this patient, remember, this is, if they're looking this way, this is what side of the patient? The left side. Okay. So remember, I would teach this. We're going to put all of our valves on here. So I would always tell them, Pam is on the left side. Okay. Meaning the pulmonary valve, the aortic valve, and the mitral valve. Okay. That leaves us with one other valve, right? On the right side. What's that valve?
Tricuspid.
Tricuspid valve. Very good. So on the right side is the tricuspid valve, right? So if we look at that question that's in there, they say aortic. Nope, it's not on the right. Pulmonary. No, because that's on the left, and mitral valve is on the left. So the answer is B, none of these. Very good. Try pulling my aorta to help remember the valves. Yeah, right. I'm like, try pulling your aorta. Oh my gosh. But yes, very good. So definitely, you know, I just say Pam's on the left side. And that seems to help everyone be like, okay, if I have those three on the left side, on the right side is tricuspid. Or I would say Pam is never right. Meaning that Pam is on the left, right? So Pam is never right. And then I had a student named Pam, and then she was like offended that I said that. I'm like, I'm sorry, I didn't really mean you. I meant the idea behind it. So, all right. So, any other questions? I know we had like a slew of different stuff today, so that's good.
The one that says the murmurs best auscultated over the left second intercostal space in patients.
Good. So left second. So remember, if we have 1, 2,
Second.
the first one here is going to be pulmonary. Okay.
Ah,
Yeah.
okay.
Over here, so you're going to be more of like that 3, 4. Mitral valve is 5th. Remember that.
Okay.
Okay. Oops, my mitral valve stay there. All right. Which valve do we see the most issues with when it comes to cardiac disease? Mitral, good, very good. You'll see mitral valve insufficiency all the time, right? Every single cavalier that you see come in, you're like, oh, you have mitral valve insufficiency. Okay.
And usually with cats, it's going to be the valves, right, issue. And then for dogs. For dogs, it's
Dogs
usually,
yeah.
yeah, I'm sorry. And then for cats is the opposite, right? They're usually
You have hypertrophic cardiomyopathy a lot of times.
yeah.
What's the difference between HCM and DCM?
DCM is when there's like a buildup or a back, what do you call it?
So let's think of the heart, okay? So the heart muscle itself, we're looking at the ventricles in both of these, okay? So with hypertrophic cardiomyopathy, the walls of the ventricles get very thickened, which creates less space for that blood to get into the heart, essentially, to pump, okay? So the walls get very thickened. With DCM, it's dilated cardiomyopathy. So that means that the walls thin out because it's dilating out, okay? And so then it's hard for it to pump because those muscles are really thin at that point. That makes sense? And so that's why you'll see with patients with dilated cardiomyopathy, they'll pass out a lot because they can't pump all of that. They can't pump the blood well to get to where it needs to go, right? So there's no blood, there's not enough blood going to their head, and then they pass out, right? Yeah, good, syncope, right? So we see that a lot in boxers. I've seen they pass out a lot, okay? Because again, they're like trying to boxers are crazy, right? They're so happy and they want to do everything, and so they're out on a walk, they're running and whatever, and all of a sudden they pass out, and people are like, oh my gosh, they're dead. No, they're currently not dead, but take them into the vet right away, right? Yeah, Danes too, you see. So there's certain breeds that obviously have a predisposed condition to that. And that happened, by the way, before we had legume food, right? So now we want legume-free food. Okay, I don't say grain-free because like it wasn't grain that was the problem. It's legumes that are the problem. There's not enough taurine in the food because the legumes suck up that taurine. And so that can create dilated cardiomyopathy. But what we don't know is that are certain breeds already predisposed to dilated cardiomyopathy and it's not really the food. Okay. Yeah, the lentils, anything. So even look up, because a lot of people don't know like what truly is a legume. And so look up what fits in that category of legumes. Okay. Like peanuts are in that category. And so I was sitting there going, well, like we give peanut butter all the time to patients, but it's probably not enough to like actually create anything where like legumes is a huge amount in that food. So just keep that in mind. But yeah, it could be lentils, it can be peas. So if you see peas in diets, like we kind of want to avoid that as much as possible. And we definitely want to avoid that with animals that are predisposed to DCM. So with that one reporting, I won't even say it was a study because it wasn't big enough and they didn't actually study anything. It showed a lot of like our golden doodles were a huge group of those animals. And so now they have to look at, are goldens now predisposed to DCM that we didn't know? Like maybe that's just over time created this problem, right? So yeah. Very good. Cardiac things are interesting once you like really dig deep in them, but you don't have to do that now. Cool. Oh, I'm glad you like cardio. I have a student now who's working in cardio, so that's pretty fun. Oh, you did it for 2 years. That's great. Yeah, so we can get all of your info. You probably know way more than me on cardio. Great. Well, let's work on our stuff for this week. So this week we are going to be, you guys are going to be finishing up obviously imaging, dentistry, large animal, and then next time we meet, we're going to go over a medical math even further. So anything else that you see, again, that medical math can include stuff from anesthesia. It can include fluid therapy, which I know someone mentioned fluid therapy too. And then if you guys still have questions on imaging, dentistry, especially, we can go over dentistry for sure, and then large animal as well, if there's anything on large animal. I will try to find that video that Danielle mentioned and then post that to in the Facebook page if Danielle doesn't do it or whatever, but that way you guys can see it. So for equine imaging, since she said it was really good. So yeah, I hope you guys have a good weekend and week coming ahead. It'll be really hot by me, so hopefully it won't be too hot for you.
Quick question.
Yeah.
I messaged you somewhere about resetting my quizzes. This is just personal, sorry.
Yes.
I haven't been able to do a few. I was just wondering.
Okay,
Good.
let me do that
Reset
right. Let me do that right now. I apologize. I forgot about that.
That's okay.
Yeah.
I'm behind actually because I got COVID recently, so
Oh, got it.
it's been super fun.
Yeah, if I can't reset it, I will send you a link so that you can like re-log in or something like that. I'll figure it out. So
Thank you.
and I hope you are feeling better. So
I am, but brain fog is like
the
actually
thing, right?
a real symptom that, yeah, I felt pretty dumb for a few days. So
Yeah, totally understand.
Yeah.
All right, let me do that and then I'll find that video. If you guys have anything, always just reach out to me, as you know, and then yeah, post things in the group page or the chat or whatever so that if there are things that you're questioning or whatever, it's going to help everybody. So yeah, I will talk to you guys in a couple weeks and talk to you throughout the week.
Thank you.
Yeah, take care. Bye.
Bye.
So our next one is on the, sorry,
11th.
on the 11th. Okay.
Yeah.
Thank you.
Yeah, of course. All right. Have a good weekend, guys.
Thank you.
Bye.
You too.